Again, good afternoon and aloha, everyone. Welcome to our Queens West Oahu Virtual Speaking of Health Lecture Series. My name is Eric Barsatan, and I'm the Manager of Physician Relations and Medical Staff Services here at the Queens Medical Center, West Oahu. Today's Speaking of Health topic is sore throat. Right now, throughout the presentation, if you could ask all our viewers to be on mute. If you have any questions, please type your questions in the chat box, and our speaker will answer them at the end of his presentation. And this time, I'm honored and privileged to introduce our speaker, Young-Suk Kim. Young-Suk Kim is an advanced practice registered nurse at the Queens Medical Center West Oahu After Hours Center, specializing in treating both adults and children's health conditions. Welcome, Young. You may now proceed with your presentation.
All right, aloha, everyone. My name is Young-Suk Kim, but I just go by Young. I'm a nurse practitioner at After Hours Center. I'm glad to present this presentation for you guys. So I'm gonna talk about sore throat. Sore throat is very common. So we can, everyone experience some sore throats, here and there, for their lifetime. So sore throat. We can pass on to the introduction. So sore throat, same as pharyngitis. The pharyngitis is one of the most common conditions encountered in outpatient clinic practice. Most cases of acute pharyngitis are caused by the respiratory virus and self-limited most of the times. However, the symptoms of viral pharyngitis broadly overlap with the pharyngitis caused by the important treatable causes such as group A streptococcus, or I'm going to say the strep A. Using systemic approach to diagnose can help reduce the inappropriate antibiotic use by identifying which patient require testing and then treatment for the strep A, and can also help determine which patient have serious conditions such as HIV or COVID-19 or life-threatening complications. Next. So epidemiology. So 12 million visits, or 1 to 2% of the ambulatory care visits in U.S. So the sore throats are peaks in childhood and adolescence, and actually it's getting less, and I mean declines after age of 40. So that's good news for after who are in after 40 years old. Next. So etiology and the clinical features. The infectious, so I'm gonna discuss with infectious causes and the non-infectious causes. So first, infectious causes cause mostly respiratory virus, include COVID-19. So two most common infectious causes, respiratory virus and then strep A. Most patients with the pharyngitis of the causes, any causes present with a sore throat that worsens when swallowing, neck pain or swelling due to regional lymphadenopathy commonly accompany sore throats, and fever, headache, fatigue, malaise are variable present. The specific microbiology causes pharyngitis can really be distinguished based on the clinical features alone. However, understanding the relative prevalence of causes of pharyngitis and their clinical features can help focus evaluations. So the respiratory viruses are 25 to 45% of cases. Include adenovirus, rhinovirus, coronavirus, include COVID-19, are most common, the viral pharyngitis. And also other respiratory virus that causes pharyngitis include enterovirus, influenza A and B, parainfluenza, and then RSV. Okay, so and then I'm going to talk about the group A, Streptococcus or strep throat, strep A. So the most common bacterial causes of the acute pharyngitis, 5 to 15% of cases, present with acute onset of sore throat, fever, pharyngeal edema, patchy tonsillar exudates, and then prominent tender anterior cervical lymphadenopathy. As you see the picture, you see the exudates and the swelling of the tonsils. Who has this? And the other symptoms, yeah, next. Okay, so symptoms are like blood spilling, teeth foam, as you see in the pictures. Strep A and last complications such as rheumatic fever, tonsillar cellulitis, meningitis.
Young, for some reason, I'm unable to hear you.
Can you repeat?
Yeah, we can hear you now. You can speak up close, louder and closer to your mic, please. Thank you.
Oh, okay. So next page. So other bacterial causes of the pharyngitis is group C and G streptococcus, and then some other bacteria as listed, and then HIV, gonorrhea, and syphilis. So group C and G streptococcus are generally considered to be less common causes of pharyngitis than group strep A. It's about 5 to 10% causes of pharyngitis. So group C and G is clinically indistinguishable from group A, but we usually don't treat group C and G because it's not associated with rheumatic fever or other immune-mediated complications. And then next page. And then other viruses like Epstein-Barr virus and then herpes viruses. And I'm going to talk about a little bit about Epstein-Barr virus. So Epstein-Barr virus, also known as human herpes virus 4, is a member of the herpes virus family. It is one of the most common human viruses. EBV is found all over the world. Most people get infected with the EBV at some point in their lives. EBV spread most commonly through the body fluid, primarily saliva. EBV can cause infectious mono, also called mono. Commonly featured include moderate to high fever, marked fatigue, and then tender, and then systemic posterior cervical lymphadenopathy. Similar to group strep throat, The mono has patchy pharyngeal exudates, and then palatal petechia may be present. Tonsillar swelling can be severe. But in contrast with other forms of pharyngitis, symptoms caused by acute EBV infections are prolonged, often lasting 2 to 3 weeks. Okay, and then other common types of the sore throat is herpes virus, herpes simplex virus. Pharyngitis can be presenting symptoms of acute HSV infections even in the absence of oral ulcers. In a case series of 35 young adults with HSV-1 pharyngitis, the most common finding include pharyngeal erythema and or exudate and the cervical lymphadenopathy. Fever and oral pharyngeal ulcers were less common, affecting approximately 35 to 40% of patients. Okay, and so non-infectious causes of the sore throat is next page. So allergic rhinitis or sinusitis, that's very common, especially the pollen seasons. And the GERD can present the sore throat and then cough. And of course, smoking exposures, secondary hand smoking, exposed to dry air, especially in the winter, and then trauma like caused by tracheal intubations or and then vocal strain, like you go to karaoke and I spend like 3 hours and sing along, that can cause the sore throats. And then medications such as ACE inhibitors and some chemotherapy medications. And then I'm going to move on to the evaluations. So before we evaluate the patients, I want to discuss about the red flags. So in these cases, I strongly recommend patients sent to the ER. People who has airway obstructions, muffled or hot potato voice, drooling or pulling of the saliva, stridor, respiratory distress like tachypnea, dyspnea, retractions, and then like tripod positions like in the pictures, and then deep neck space infections like severe unilateral sore throats, bulging of the pharyngeal wall, soft palate, or floor of the oropharynx, and then crepitus and the trismus and a stiff neck. If we see these patients, yeah, we recommend send to the ER for immediate evaluations. And the next, so right now during the COVID-19 pandemic, so sore throat is very confusing, especially after Omicrons. The most people who have COVID-19 present with the sore throats. So CDC recommend tests for COVID-19 people who have a sore throats. Everyone, yeah. Okay, so sore throat with the respiratory virus syndrome usually present with fatigue, nasal congestions, cough, runny nose, conjunctivitis, sneezing, hoarseness, ear pain, sense, discomfort, oral ulcer, and then other viral exanthems are additional features of supporting the diagnosis of the wider pharyngitis. Cervical lymphadenopathy may be present, but generally not prominent. On the next page, gonna be like who need a test for the strep A. So we need to figure out is this is virus or is this the strep A. So determining whom to test for the strep A is sudden onset sore throat with the fever or tonsillopharyngitis and or uvula edema, patch tonsillar exudate, this is really important, and then cervical lymphadenopathy, and then skeletal skin rash, and strawberry tongue, and history of group A, strep A. And then we also, there is criteria called center criteria. As you see, the white X-ray is really important. So people who are presented with a fever, no cough, and then tender lymphadenopathy with a tonsillar exudate, there's a 1, 2, 3, 4 the points. If it is more than 3 center criteria, we definitely test and then treat. Yeah, and then if it is a 2, oh yeah, I'm sorry. If it is more than 4, we just confirm with the lab and then treat with antibiotic. If it is 2 plus, we do the sore throat and then a throat swab or rapid, you know, strep test. And then if it is positive, we treat. If it is 0 to 1, yeah, likely strep, it's likely the virus. And the next one is treatment options. The next page. Yeah, so treatment for the pharyngitis usually start with symptom control. So like oral analgesics, like NSAIDs, acetaminophen, topical treatment, gargling with warm salt water, viscous lidocaine, those are options. So according to the study, NSAIDs are slightly better than acetaminophen. So you recommend to take the ibuprofen, naproxen as needed, and then generally act within 1 to 2 hours to relieve sore throat symptoms. And in addition to the oral analgesics like ibuprofen, I recommend to use the approach as topically. So apply locally through the throat via lozenges or spray or beverage or food like ice, tea, soup, or honey. So these are generally quicker acting than oral analgesics and then typically have a short duration of pain relief and may necessitate frequent redosing. Um, So for patients with significant sore throats, hydration with frozen food, such as ice and popsicle, or warm liquid like a tea or soup, rather than room temperature or refrigerated fluid, may provide a relief. Food like that hot the throat include like honey, hard candies, lozenges, can be facilitate intakes of calorie while temporarily relieving sore throat pain. Yeah. And then gargling with a warm salt water, gargling with a warm salt water is recommended as well. Um, So most recipe is quarter or half teaspoon of the salt per 8 ounces of warm water. So I recommend it. And then viscous lidocaine is prescriptions, and then it's very effective. It comes, it's very thick liquid. So if it is too thick to use it, you can mix it with water and then you can gargle it. And then we don't recommend use the glucocorticoid because according to the study, it's not really working. And then don't use antibiotic if it is not a strep. Prescribing antibiotic when they are not indicated puts the patient at risk for antibiotic side effects and increase the community risk of the bacteria resistance. That's why we don't recommend unnecessary the antibiotic. Next page. And then yeah, other the therapies applied topically is like lozenges include menthol, dicyclomine, or benzocaine, and then there is over-the-counter like throat sprays with the phenol or the benzocaine. I think I talked about the fluid herb food. Okay, and next page. So we need to figure out like we already discussed like who needs a strap and who needs antibiotic for strep. So, who is positive for strep need antibiotic. Um, so why we need an antibiotic is antibiotic treatment has shown to reduce the symptoms severity and hasten the rate of recovery in patients with the strep. So strep throat. However, even without antibiotic therapy, the symptom typically resolve in 3 to 5 days for the most patients. Uh, but we want to prevent the complications. Um, so the complication could be suppurative complications, include otitis media, peritonsillar abscess. And then non-sportive complications acute rheumatic fever, and then the post-streptococcal glomerulonephritis. So I'm going to talk a little bit about the rheumatic fever. So this is the main indications we're using the antibiotic like penicillin. We want to prevent it. So acute rheumatic fever and then rheumatic heart disease are important causes of the cardiovascular death worldwide. According to the study, randomized trial comparing penicillin with placebo in over 8,000 adults and children with sore throat, penicillin decreased the risk of the rheumatic fever by 2/3. Absolute risk reduction is likely highest in children aged 5 to 15 residing in developing nations, where where incidence of rheumatic fever peaks. And the preventions of transmissions. So strep A can spreading among the close contact, just like COVID is a droplet, leading to clusters of cases, and then in the current infection in the household and or other close contact setting. So rate of strep throat transmission from infectious cases to close contact is estimated to between 5 to 50%. Although no study have directly evaluated the effect of antibiotic treatment on transmission, antibiotic use appear to eliminate strep throat from oropharynx in about 80 to 90% of cases after 24 hours of the therapy. And then, so what antibiotic we use? The next. We use the penicillin for the first line, or amoxicillin for the keys, because the penicillin has efficacy, safety, and a narrow spectrum, and it has a low cost. Then there's no resistance to the penicillin, and then the only antibiotic to reduce the rate of the acute rheumatic fever. Okay? So for the PED patients, we use the lower doses of amoxicillin. So people who are allergic to the penicillin, we can use the cephalosporins such as cephaloxime and cefdinir and clindamycin and azithromycin. Next slide. So respond to the therapy. So most of the cases resolved within 1 to 3 days after starting the antibiotic. Follow-up visits are not needed for the most of patients. Most patients can return to work or school after completing the 1 full day of the treatment. So if you're starting antibiotic today, you may return to work or school the day after. So indication for the test of cure is not needed except people who has a history of acute rheumatic fever and acquire infection during the outbreak of the acute rheumatic fever or post streptococcus glomerulonephritis, and acquire infections during cluster of cases in the household or other contact settings. But otherwise, yeah, you don't have to retest it. Okay, the preventions. Next slide. Just like a COVID, hand hygiene and mask is optional now, but recommended, of course. Post-exposure prophylaxis like COVID, we had it earlier, is not recommended, but some special populations of history of acute rheumatic fever or long-term antibiotic. So people who has a history of acute rheumatic fever may need long-term antibiotic prophylaxis. And then there are some cases from by cooking. So prevention of the food through the cooking, complete reheating, and the use of gloves while handling food is really important. And then, unfortunately, there is no vaccines for the strep A or pharyngitis, but it's under development. Okay, this end of my presentations. And anybody has question? I'm sorry, I was very nervous and yeah.
Thank you, Young. That was a very excellent presentation. So right now we'll proceed with the Q&A or question and answer portion. Again, if you have any questions, please type them in the chat box right now. Okay. Actually, I have one came in earlier, and the question, Young, is that can someone get something from kissing someone?
Yes, it's like, same, it's more transmittable than talking. Of course, kissing is sharing the saliva, so of course the sharing the virus or bacteria. Yes, definitely can share.
Okay. I don't see any more questions. There is a comment that your presentation was very thorough. They really appreciate it.
Thank you.
But that concludes the Q&A since we don't have any more questions. Again, I would like to thank once again our speaker, Young, our provider at the After Hours Center at the Queens Medical Center, West Oahu. I would also like to thank all of you for participating today, our virtual audience. Again, that concludes our Speaking of Health presentation for August. And at this time, we'd like to ask all of you, our virtual audience, to please complete the evaluation information on your screen. Please click the URL in the chat box or simply scan the QR code on your screen using smartphone to complete the evaluation. Again, it is a very brief evaluation, so we'll give you a few moments. As always, we'd love to hear your feedback and comments. And please make sure you don't log out after you complete your evaluation. Okay, and I think everyone is done with their evaluation. So again, the Queens West Oahu Virtual Speaking of Health Lecture Series is the third Thursday of each month at 12 noon to 1 p.m. Please join us for next lecture, which is scheduled for Thursday, September 15th, and our speaker is Louise Gwincorn, our palliative care APRN, who will be talking about the value of palliative care. It is another excellent topic, so look out for the announcement, which will include the registration information. We hope to see you then, and feel free to share or forward information to your friends, family, colleagues, and everyone you think may be interested. On behalf of our COO and Senior Vice President, Darlena Chadwick, our Chief Medical Officer, Dr. Ronald Kuroda, and the entire Queens Medical Center West Oahu Ohana, mahalo nui lua. Thank you very much for joining us today. Until next time, please take care and always be safe. Aloha.